to Dr. Dhruvi.
Thank you, sir. Thank you. By the time we have our slides, I think we are at a top where it is very, very important to talk about pediatric diabetes. A few years ago, we were having a camp at Sir's, center in Surat, and we do see firsthand that there are a lot of challenges that we are facing with pediatric diabetes. For that matter, we have Parikshit sir, we have Sandeep sir, we have Piyush sir, Vipul sir, and all who do a lot of work with kids who are, let's not call them suffering, but who are living with type 1 diabetes. And in the past 3 months, it was Pratap sir, it was Banshi sir, it was Sandeep Patak sir. All of us were, rotating some slides between us. कि ध्रुवी यार challenges वाली slides छे, आपके पास है solutions वाली slides छे, and it so happens that the slides have not changed, the challenges have not changed, the solutions are there. We are trying to bring upon newer and newer ideas, but it still remains the same, and that is what we were talking while we were moving around with Banshi sir. कि अपने slides में same to same बात करें, should we be changing the subject to making it newer challenges? But we are yet to overcome the existing ones, and there is yet so much of work that needs to be done in the existing environment. And there is a whole big conference called the International Society of Pediatric and Adolescent Diabetes, and I guess we were all there in Hyderabad 2 years ago when we did it in India. And there are doctors who remark on the amount of lack of resources that are there in India. But we are also one of the best doing countries despite of the lack of resources. And the average A1C through the registry of SWEET, that is under the ISPAD, our average A1C is something between 8 and 9, which the Western world also has the same. In spite of using just, biosimilars, in spite of using syringes, we are still doing just as good. So we are doing something special. And, instead of just focusing on the negative, I think we should be focusing on what different we are doing and how great we are doing. So I'm just going to quickly go through some slides. Can I put this mic away, if that's okay? Yeah. So this is the prevalence slide. Thank you. There is actually a dearth of data as to what is the exact epidemiology of pediatric diabetes. Again, when you want to define pediatric diabetes, it becomes a little difficult because people have that notion that pediatric diabetes is equal to type 1, which is not so. Pediatric diabetes is a conglomeration of all the kinds of hyperglycemic conditions that are present in kids, adolescents, and toddlers. So this is a rough idea of atlas, which might not be showing the true epidemiology because we are not very good with the data recording. But type 1 diabetes between 0 and 14 years in India is the prevalence is somewhere between 95.6. Now this was a slide from Pratap sir's slide set, and he said that there are some essential components which we have to always mention when we are talking about managing type 1 diabetes. It is medical nutrition therapy, of course, physical activity, insulin therapy, monitoring, diabetes self-management education. I see quite some educators sitting here in the back of the auditorium, and I guess they are from Parikshit sir's team. And it's very important that we empower our educators to be able to counsel our patients very well as to what exactly self-management means. And another thing that we should emphasize more on after even the Olympic champions are taking a break because of mental health is psychological support, the psychosocial support, which needs to be emphasized even more. So let's talk what are the challenges. Again, this was a repetitive slide. Pratap sir is quite fond of this slide, and I think all of us use this because it divides the sphere of management of type 1 diabetes into various kinds of problems, from an individual problem to healthcare professionals related troubles, to the system related troubles, to community and cultural challenges that we all need to address. Another major strong factors that we generally do not talk about is lack of awareness, marital issues, the chances of insulin initiation, the economic constraints. Of course, we all talk about we are the treasurers. Malay, welcome for that. Diagnostic challenges, and the insulin storage, which we should address. This was a paper by Jyotidev sir. He's one of the technological experts and pioneers for type 1 diabetes. And he said that there are various patient-related as well as provider-related contribution to all of these factors which we should be addressing. This is a paper by Pratap sir, Sabu sir, and myself, which we got out during the COVID-19 pandemic time, saying that there are special challenges when we are talking about management of children and adolescents with type 1 diabetes during the time of COVID-19 pandemic. So let's now just divide these challenges into three major parts. Let's talk about self-management. We'll talk about the healthcare system, and we'll little bit brush up on the psychosocial aspects. Now, like I said, diabetes self-management is very, very essential and starts from teaching a proper insulin injection technique to glucose monitoring, to medical nutrition therapy, to physical activity, as well as problem solving, carb counting, coping up with peer pressure, to coping up with parental pressure. And all of these components are increasing in their strength with the current lockdown, I guess. Parents being all the time with their kids, and especially with the type 1 kids, they are very, very empathetic about the fact that ye karo, wo karo, ye mat karo, wo mat karo, and that's the kind of pressure that kids are dealing with. Let's talk about insulin therapy, and we all know that accessibility of insulin. Even in the US, one of my friends, she's in the States right now, sir, for the Allen Rash fellowship, and she said, "Mare $650 no insulin therapy padyu, despite of having insurance." So even if the developed countries are having trouble with accessibility to insulin, what about India? We know that in the periphery, accessibility of insulin is still a problem. Education on what biosimilars are, on what human insulin are, and what analogs are is still a problem. And if you talk about pumps, it is something that is a total no-no. People feel that there is something like a remote which you're controlling my kids with. There are a lot of proposed solutions, and RSSDI has a type 1 diabetes network, and it is also supporting the doctors for providing free of cost insulin, glucometers, strips, and care to the doctors who want to support kids with type 1 diabetes. Glucose monitoring. Again, we all know we are conducting debates on SMBG and continuous glucose monitoring at a time when time and range is a parameter. We are still talking about the difficulties which are there with SMBG, availability of strips, availability of glucometers, and again we have our RSSDI Act, as a savior. They are circulated the list of contact numbers of all the nodal people for glucometer, ketone strips availability, and or any of the doctors who want to avail this maybe can write to us. Pratap sir is sitting here. Medical nutrition therapy. Again, there are lots of myths, lots of facts, lots of prejudices which are related with medical nutrition therapy. And, the proposed solution is not valid, but the one thing that needs to be done is education. Education of all the associations who say that we are supporting type 1 diabetes groups need to be educated that there is something known as a healthy diet. There is nothing like a diabetes diet, and not one glove fits everybody. There needs to be an individualized approach, and please, consult a person who is a registered diabetic dietitian or a nutritionist, or talk to a healthcare professional, a diabetologist, or a physician, or a healthcare professional for that matter. Physical activity again. Once a parent comes to know that my chokra ne type 1 diabetes or just hyperglycemia hai, they have that notion they cannot play, they cannot do any kind of other physical activity. But there are type 1 athletes, swimmers, footballers, and with the correct amount of education, again the term that we use, education everywhere, which is the main solution. With the correct kind of education, counseling, every kid can lead a normal life. We do a regular type 1 diabetes challenge, wherein we take all the kids with type 1 diabetes for a trekking, for mountaineering through the RSSDI, and it has not been done after the COVID, but I guess we should have some opportunity. But local support groups again can be encouraged to organize camps wherein kids and the parents are taught on how to take care of their child's glycemic status during a regular physical activity movement. Another thing is sick day management. Sick day management, how to take care of your child, how to take care of yourself if you are type 1 diabetic, especially for teenagers who contract even smaller infections or stress related hyperglycemic episodes are very prone to have DK or hypoglycemic episodes, and these two are major situations which need to be highlighted. And again, the solution turns up as education, counseling through diabetes educators, through nutritionists, and through education of the local support group. There is a very nice table as to what needs to be done during an emergency for a type 1 diabetic. A small emergency kit needs to be made as to what it should contain. It should contain glucometer, some glucose tabs, insulin, of course, ice pack, some gauze swab, and the contact number and the details of the emergency person to be contacted for the child who are in school. Even for teenagers, they can wear bands as to who to contact. There are diabetic bands, diabetic eye cards which we've made, and all of these need to be taught to the parents, taught to the support group, taught to the children, taught to their immediate peers and immediate relatives who need to be educated on what needs to be done during emergency. An upcoming thing which needs to be addressed is type 1 diabetes and COVID-19. Our paper here by Pratap sir did emphasize on what needs to be done. There was an NHS funded study that stated that type 1 diabetics are 3.5 times more at a risk of in-hospital death with COVID-19. So again, a glycemic profile, if there is a stable glycemic status and you get COVID-19, you have lesser chances of mortality and morbidity in comparison to if your sugars are uncontrolled. This needs to be educated to, again, all our patients, and there is nothing to panic. This was the table I was talking to you about, an emergency preparedness plan for type 1 diabetes management during COVID-19, a list of documents, a list of medical supplies, and a list of other materials which can be gathered up and kept in times of emergency needs to be taught. Now this was all some general challenges related to diabetes self-management. Let's talk about the healthcare system. A simple routine support of a type 1 diabetes needs a holistic care. You know, it cannot be a one person, one doctor taking care of the child or educating the parents. A first visit to the doctor for a type 1 child in the European and the US consists of a full day education and sometimes a week, because they teach them different kinds of self-management and physical activity and medical nutrition therapy. And in India, it gets smaller to less than 15 minutes. So that is why we need a whole holistic team approach for teaching our the parents again and our kids with type 1 diabetes as to what needs to be done. Telemedicine guidelines are very much up and about. The Ministry of Health and Family Welfare have also approved the use of telemedicine, constant contact. A dedicated staff can be given the responsibility of following up with the type 1 patients. And there are several web-based tools. There is EHR, there are several applications that can be used very well for documenting the SMBG readings, for documenting their sensor readings, for documenting the insulin and the food also which they have taken, along with the vitals and physical activity. So if this is propagated well through our healthcare system, through our educators, through our nutritionists, or even by a medical officer, that can help our patients very well. Again, let's look at the point of emergency issues related to glucose control from the side of our healthcare system. Proper management of hypoglycemia and proper management of diabetic ketoacidosis. Like somebody was stating yesterday, Ishwar sir was stating yesterday, average DK and hypoglycemia thodi shiki. So the critical care specialist who is actually managing emergency situations need to be propagated this idea as to an appropriate in-hospital management of hyperglycemia, even for type 1 kids. They get scared by the moment they come to know that this child or this teenager is having type 1 diabetes. And even for adults, if they are on pump, they would move them to, an MDI, or if the child is even still taking pens, they would shift them to syringes. And a proper education of critical care specialists even for a small period of time, as to how to take care of this is necessary. Technical issues are always there, whether we use a pen, syringe, or pumps and sensors. These are various kinds of sensors and pumps that are available. Medtronic is the only pump company in India, but still there are different models of the pump. There are issues that technology can put forward as obstacles in front for the patient, for the doctors as well. And proper education, 24/7 technical support. Medtronic does provide that, but they have a very small staff. So we can all have a small insulin pump workshop sometime, and we have all stalwarts here who can talk more about insulin pump for that matter. Psychosocial aspects. Again, brain is a very, very tricky thing, and a lot of non-diabetic people also go through psychosocial issues. And imagine somebody with a chronic disease, not even diabetes, a chronic disease, undergo a lot of questions, a lot of anxiety, a lot of depression. And a child, for that matter, thinking you manage can diabetes. So why am I the only person who's different out of my peers? Why am I the only one, not doing this or doing a particular thing in a particular way? So there are various anonymized groups also who are working together for the betterment of the psychological status of kids. There could be some fun-filled activities that can be taught. There could be play game areas which in a fun way can teach how to manage diabetes. Educational institutes, again, education plays a very important role in clearing the myths and prejudices that are linked to management of diabetes that are causing psychosocial problems. Like Sir said, finance is a very, very important thing, and all of us would agree to that. And financial aspects also add on to the psychosocial burden. Somebody who cannot afford to buy insulin and we tell them that kaju badam khao is not a practical thing. An individualized approach. Even people who are on syringes have immensely good glycemic control without hypoglycemia, and they are some of the patients who follow our instructions to the T, have a glucose diary, do a proper SMBG, are properly taking insulin without lipodystrophies. So this financial trouble is something that we have to look into through an individualized base for our patient from one to another. So you cannot be writing a syringes to a person who's very, very affording and literate. You have to look, and you cannot be writing a pump to somebody who's underprivileged. So you have to be individualized in that approach as well. These are various different solutions that we can get or do for an optimal glycemic levels. There is a lot of diabetes technology, which I think we need more time to talk about. Exercise, nutrition, adjunctive therapy, medical home, there is psychosocial support that needs to be done. There are family dynamics. There are grandparents who fuss upon their kids, why are you troubling the kid? We'll look into the matter. There is so much of resilience, there is so much of resistance to the fact, so much of denial at the start and even during the course of chronic disease as to that needs to be addressed. You have to understand and make the family also understand the gravity of the situation that hyperglycemia comes with. And there are a lot of type 1 diabetes communities that you can refer your patients to. Talking to a person similar in the kind of situation you have is quite soothing. It's quite comforting to know that, oh, tamara paas bhi pump hai, even I am on pump. Are you taking insulin? That kind of a thing helps the kids a lot. Knowledge, capacity and capability and willingness to enact any kind of care plan needs to be there in a healthcare professional while dealing with type 1 diabetes. This is the type 1 diabetes network and insulin project that RSSDI is taking up. Again, a very, very older slide, but a holistic support, a holistic care needs to be there. The kids would say that, be there for us. There is a need for infrastructure, healthcare professional training and education, need for free insulin and supplies, which is being done by RSSDI, patient education, need for a diabetes registry, which hopefully will soon be coming up by this World Diabetes Day, and learning the outcome. We have to analyze what kind of management we are doing and what kind of intervention needs to be done further to better the lives of people with type 1 diabetes. This is our perspective through a type 1 diabetes registry in developing countries. This was a paper that Banshi sir and myself, we were a part of to talk about the perspective of a developing countries. Again, we are in a very paradoxical situation wherein we have super rich, super underprivileged, and then there are middle people who really don't know which side you want to put them on. And you have to identify individualistic challenges and give proper individualistic solution. Again, one size does not fit everybody. With that, I'm going to stop talking. These are various kinds of camps that we are organizing, and diabetes education is the only answer and the one key that can open all the locks. So thank you all for your patient listening. Thank you.
Excellent lecture.